Good afternoon, everyone. We're going to call the Pension Health Committee meeting to order. The first order of business will be to call the roll, please.
Rob Fickner.
Good afternoon.
Teresa Taylor. Here. Matthew Seha for John Chung.
Here.
Richard Gillahan.
Here.
Henry Jones.
Here.
Priya Mather. Here. David Miller.
Here.
Bill Slayton.
Here.
Alan LaFossa for Betty Yee.
Here. Thank you. Next item is the executive reports. Ms. Bailey-Crimmins and Ms. Lum, please.
Good afternoon, Mr. Chair. Donna Lum, CalPERS team member. This morning in my executive report, I wanted to take the opportunity to share with you some highlights of some of the work that we've been doing with our employers. From month to month, I tend to share a lot of information with you about what we're doing to service our members. However, our employers, as we also refer to as our business partners, are a real key part of the organization and the services that we provide. So in my report, I want to share with you things that we've been doing to specifically increase our engagement with the employers, how we provide education, what we're doing to increase compliance, to avoid audit findings, and ultimately a number of things that we're doing to enhance their experience with us. So for some of you that have been with the board for a while, you know that during a stakeholder survey that was done in 2012, we received a lot of feedback from the employer community with specific information on how we could improve the services that we provide. And the one thing that was very common in the feedback that we received is our employers wanted a specific individual that they could contact consistently whenever they had sensitive or urgent inquiries, someone that they knew would be able to follow the inquiry from end to end and provide a timely response. So we set out with criteria that was very different on why employers would call this group versus the contact center. And from that experience came what we called the Employer Response Team. We launched the Employer Response Team in 2013, and since then, our response team has helped hundreds of employers very satisfactory in resolving their critical needs. Well, we figured that that would be one good use of our resources. We also identified that we needed to do something that was more proactive, and we needed to find a way that we could reach out to the employer community to determine what else could we do, what were their pain points, and from a customer service perspective, where did we need to focus our time and attention. As a result of that, we then created what we called the Employer Response Dialogues. And these dialogues were set up as very small venues where we could interface with our employer community on a small scale, but on very, very important items. We launched the Employer Response Dialogues, and we host them at all of our regional offices and sometimes in remote locations where we know that we have employers that are interested in dialoguing with us but would have a longer commute to do that. Over the past few years, again, we have implemented several of the dialogues, and the survey responses that we get from these dialogues have been really good. They are exceeding 90 to 95% in the satisfaction. But just to give you an idea of some of the topics that we talked about, so in 2013, obviously PEPR was a main issue, and we were helping the employers kind of navigate through and understand what was being required of them. From there, we had a number of things with regards to what are the common audit findings, how can we help you with that, how can we help you with working after retirement issues, reciprocity issues, all the way through 2018, where we've had team members from our actuary office who have joined us at these ERDs and who are talking about things like the amortization policy as well as asset liability management. So I think it's been a really important venue for us and mechanism for us to do face-to-face communication with the employer community, and we know that they're very appreciative of that effort. In addition to that, since we do have a small team that travels to host these response dialogues, we also do some research before we go out there to identify if there are other employers in the same general geographical area that have special needs. Either they have dialogued with us around some audit findings or some very complex issues that we would need to discuss with them one-on-one as opposed to even in a smaller venue. And I'm happy to say that as we have done this travel travel and have gone out to the ERDs, over the last year, we've hosted more than 17 of those one-on-one meetings. And what we've been able to see is a really good response from the employers. They are able to address those complex issues. We're seeing audit findings that were aged, that were taking quite a long time, primarily because they didn't know the right questions to ask and they didn't know who to go to get information. And we're seeing things like that being closed. So those are just a couple of the things that we've been doing very proactively and going out and reaching and having these face-to-face dialogues. But we've also been marketing some of the other education opportunities that we have. Our employers know that we have the Ed Forum. We also have online education that they can participate in, as well as whenever we receive interest from an employer who may be wanting to host, for example, a retirement fair. We do send team members on site to be able to help with that. Specifically, more recently, we know that there are some schools that have had some special needs. They have large retirements that are taking place. And there again, we send our team on staff and on site, and they're able to help with the retirement applications and help with doing counseling right there on site. Another just example of where we're seeing benefits from this direct outreach that we've been doing. In past years, we know that we've had a number of issues with employers submitting payroll timely. And when CalPERS doesn't receive timely payroll, it impacts a number of things, and that includes member benefits from being paid timely. I'm happy to say that with all the outreach we've been doing on payroll-specific items, as well as the increased capabilities that we've had with the CalPERS system, nearly 100% of the employers are submitting their payroll timely. This avoids things like fees, because we recently implemented legislation that would enable us to assess fees when a payroll isn't submitted timely. But I think more important, not only just getting this interaction and the payroll timely, it's the partnership that we are forging with our business partners, our employers, through all of these interactions. So again, I just wanted to take a little bit of time out of my executive report just to give you some insights to, I think, a lot of the great work that the team has been doing with our business partners. That being said, I also wanted to share some information with you, as I always do each month, with regard to our latest CalPERS Benefit Education event. On March 23rd and 24th, we held the CalPERS Benefit Education event in Redding, California, one of the most northern points of California that we go to with this event. This is considered to be one of our most remote locations because the nearest regional office is here in Sacramento, and it's about a 2.5-hour drive. We served well over 750 members at this location. And again, it's always nice to have the team interact with the members, and we know that they really appreciate the work that has been done out there. During our CBs, we issue surveys, and we're always pleased at each of the sessions to review the surveys. They provide us with very constructive feedback on things that we can do to improve sessions, but they also give us feedback on how well the session has been conducted. So with that, I just wanted to read to you one of the statements that we got back on one of the surveys from an anonymous member. And it said, "I am amazed at the magnitude of this seminar. It's much more than I expected, and thank you." And I think it's a real good sentiment of, again, the interaction, the work that the team is doing, and we know that the members appreciate these events. It does take a lot of work throughout the enterprise, not just in the customer service teams, but we have many other groups that participate. So we did, again, the team was very pleased to see Mr. Fechner there at the Redding event. And just to remind you that our next event is going to be held on May 11th and 12th, and that's at the Olympic Valley up here in California. So, Mr. Chair, that completes my report, and I'm happy to take any questions that you may have.
Thank you, and I do want to say that when I went into the general session, it was nice to see that you had a trailer up there on the screen before the session started, like trivia questions and things. It would have been better the Steamboat Willie cartoons, but you know, it was neat to see a lot of questions and answers coming up on the screen that would help educate the members before the session even started. So pass that along, please. I thought that went well.
Thank you.
All right, seeing nothing else, Ms. Bailey-Crimmins.
Good morning, Mr. Chair, members of the committee. Leanna Bailey-Crimmins, CalPERS team member. For my opening remarks, I have 3 highlights that I'd like to provide to you. The first is regarding an update related to the ongoing dependent eligibility verification process. The second is regarding Kaiser Permanente. Our members have been asking about Senior Advantage and when potentially they might be expanding, so I thought it would be nice to provide you just a quick little update on that. And then last, just to share with some highlights that you should be expecting from today's agenda. So the first is the Dependent Eligibility and Verification Project. CalHR and the California State University, also known as CSU, contracts with CalPERS to notify members of the requirement to verify dependents that are utilizing health benefits, and we do this every 3 years. The scope encompasses state and CSU active and retired members. It does not include public agencies and schools. And in February, CalPERS sent out 14,000 letters to subscribers that have an April birth date. And this encompasses about 35,000 dependents. Notices were sent out to subscribers at a 90-day, 60-day, and a 30-day interval. It instructed them to provide the necessary information to the state and CSU Human Resources offices they work for to avoid any dependents from being removed from their health plans. To date, CalHR and CSU have successfully verified that 75% of the dependents have been verified. There's still 25% that need to be verified between now and April 30th. If a state or CSU member has not received a validation letter, I just want to remind everybody this is a 3-year process. So once you've been validated, then the clock starts ticking for another 3 years. So if you just happen to wonder, where's my birthday, my mailing schedule, you can find this information on the CalHR and the CSU website. The prior validation project, maybe, I don't know if you're aware, was actually done by an external consulting firm. That has now transitioned to internal staff and is being done by CalPERS. But CalPERS believes in continual improvement, so this first batch of 14,000 letters, we heard from our stakeholders and we will be making a few changes. The most prominent is to revise that third letter, that 30-day notice. We think that we need to clarify some due dates and also to align with the prior tone of the prior 2 notices. So it enhances communication and hopefully prevents any confusion that might happen for the member that receives that. And for retirees, we will be initiating the process later in the year. If they are interested in knowing more about that, that's available in the spring perspective that was just submitted or published. And as the date approaches, I promise that we'll be giving you some more information as that approaches us. Now, Kaiser and Senior Advantage, our stakeholders have been asking, when is CalPERS expanding that program? We reached out to Kaiser, and they did tell us that they are strongly committed to their Medicare program, and they definitely intend to expand in the future. But what we wanted to let everyone know is that per CMS rules, which is the Centers for Medicare and Medicaid Services, based on regulations, Kaiser's not permitted to discuss their 2019 offerings until October of this year. Once October hits, we'll then be able to let everyone know where those expansions are going to be occurring. And then today, for the Pension Health Benefits Committee, there are 3 agenda items that I'm going to first highlight. The first is a second reading of the CalPERS Health Beliefs. Great work takes time, and February marked the 1-year anniversary since we introduced the desire to establish a set of CalPERS Health Beliefs. This was a very inclusive approach. We thought it was important that our stakeholders had an opportunity to have a voice in this process, and that include members, employers, CalPERS team members, executives at the board. Second, CalPERS now believes it's time to expand our reference pricing model. It's been very successful, but we now think it's time to start looking at pharmaceuticals by therapeutic class. And so today, CalPERS will be discussing a pilot for 3 therapeutic classes. Dr. Kathy Donaldson and her team have researched and worked hard to establish a pilot that, 1, reduces the need for prior authorizations, 2, ensures that it reduces the member out-of-pocket cost, and is another step towards our goal of reducing the cost of pharmaceuticals in the future. And lastly, for our preferred provider organizations, also kindly known as PPOs, the CalPERS team will be providing you an update on the 2000 benefits. The benefits that you had voted in last year just became effective in January, so we're going to give you a quick update on that and highlight some recommended changes for 2019. Please note that there are 2 new preventative care benefits that we will be recommending, Wisdom and Spine Care. What's unique about this is there is no effect on the 2018 premium, so we will actually be able to implement them the latter part of this year. And for our members, good news, there will be no copay because they are deemed preventative services, and you're going to learn more about those programs when the agenda item is in front of you in just a few minutes. Mr. Chair, that concludes my opening remarks, and I'd be happy to answer any questions.
Thank you. Seeing none, item 3 as a action consent item. What's the pleasure of the committee?
Second.
Moved by Mother, seconded by Taylor. Any discussion on the motion? Seeing none, all in favor say aye. Aye. Opposed, no. Motion carries. Item 4 is the consent items. Had no request to move anything off of the consent. Brings us to item 5, health belief, second reading. Ms. Paulus.
Good morning, Mr. Chair, members of the committee. Karen Polish, CalPERS team member. Today I'm here to continue our conversation about the CalPERS healthcare beliefs by presenting agenda item number 5, and that's called Healthcare Beliefs Second Reading, and this is an action item. Today's agenda is going to include looking at our progress, discussing the beliefs updated with feedback, and looking at our next steps. Taking a look at our timeline, just as a quick refresher, the health team began our work on the health beliefs a little over a year ago with our stakeholder outreach, and we also included some workshops with CalPERS board members and our executives, and that ended last month with a first reading of the refined beliefs based on the work we've done together over the last 14 months, which included the January offsite workshop. You provided valuable feedback to us and suggestions on the refined belief statements. We incorporated your feedback to land on the beliefs that you're going to see here today. For our conversation today, I'm going to walk through each of the revised statements, providing some insight about any changes, and then we're going to discuss the options that we're putting forward today, and then open it up for some discussion, and then finally ask you to take action. The framework on the beliefs is actually remained the same from January through today, although the belief statements, they've actually evolved over the course of our discussions and your feedback, and that makes sense. The theme areas have actually stayed the same, which also makes sense because they are a product of the stakeholder outreach and the board and executive input that we received about the theme areas that are appropriate for health belief development. The first theme area is health program sustainability. On this slide, you can see both the January workshop draft and last month's first reading version. When we discussed the theme area last month, the committee was pretty comfortable with the overall March version. The suggestion for improvement was to eliminate the words long-term, because when we think about sustainability, it's both the short-term and the long-term that are important to CalPERS. So we accepted that suggestion, and the revised version reads that sustainability of the health program is the foremost consideration when reviewing proposed changes to benefits, coverage areas, and costs. The second theme area is high-quality care. We have both the January workshop and the first reading version here. This theme actually had quite a bit of discussion in March at the meeting. Based on the conversation, we seemed a lot closer in our January version than we were in our March version. So we actually revisited the January writing, and then we had an improvement from your feedback to remove the word must and replace it with the word should. So that currently reads, health benefit plan design should improve member health outcomes, maximize quality, and reduce unwarranted care. Next up is affordability. As you can see here, the January and the March versions were pretty similar. The difference was to separate in the March version, the affordability and the sustainability based on the stakeholder group. And similar to the high quality care, there was more preference for the January version. So we've actually reverted back to that, and it now says health premiums and out-of-pocket costs must be affordable and sustainable for members and employers. Our next area is comprehensive care. There was some really great conversation on this theme last month, and the committee seemed fairly comfortable with the overall theme. The suggestion to improve it was to key in on evidence-based medicine or evidence-based healthcare. So that's something that we took back, and we realized that CalPERS advocates for that in our health plans, so it makes perfect sense to include it in our healthcare belief. So the belief statement currently reads that health plans shall encourage healthy life choices and provide access to essential healthcare and evidence-based health services. For competitive plan choice, when you look at the January and the March versions, most of the conversation really focused around the different perspectives on the terminology competition. When we started our conversation about healthcare beliefs, you may remember that we talked about lenses and that the same issue looks very different depending on the lens that you use to look at it. As a purchaser through that lens, CalPERS uses competition between our plans to help drive cost containment and innovation. While at the same time, with our member lens, we know that we need to have competitive options for our members in their care, which is something we heard very loud and clear from them in our outreach sessions last year. So taking the committee's suggestions, the revised version now reads that CalPERS shall manage competition among health plans to help both drive cost containment and give members access to options among health plans, benefits, and providers. For the theme area quality program administration, the committee seemed pretty comfortable with the March version, so we're just going to move forward with that. And it reads, CalPERS shall meet the needs of its many stakeholders with responsiveness, accuracy, and respectful service. The last of the 7 theme areas that we have is policy, leadership, and advocacy. This statement actually had quite a bit of conversation last month. And we took that feedback and went back and thought about it. And you may recall that at the July offsite, we provided to the board, what do I want to call them, ranked stakeholder themes in importance to our stakeholders. And you might also recall that when we looked at the top priorities for our stakeholders, this was not one of their top priorities, but it was a top priority for the board, the executive team, the health team, because we recognize that it's a critical path to getting at those other theme areas that percolated up through our outreach efforts. So as the other theme areas were combined through our work and they were boiled down to their current version, this one really stayed the same. And I think it's because it was a little bit different. And I think that that might be why it feels different, is that it was really a critical part of how we think about health and what we believe that we do, but it wasn't really in those top sort of one-off, affordability, quality. This was a much more strategic belief area. So this leads to the 2 options that we're bringing forward today. There's 2 ways we can go. So we can keep the policy, leadership, and advocacy as a theme with its own belief statement, or we can move it to the introductory text that we have for our beliefs. That lays out the foundational principles that we operate under, sort of the bedrock for our belief statements. And so you could leave it as it is and have a belief that reads, as a leader, the CalPERS health program shall engage in activities that influence the state and federal policy landscape and align with other entities who share our values. The other option would be to move it to the introduction area, where we lay out CalPERS core values impact on our work, the approach that we take, and sort of our foundation for how we approach our work. And if we did that, then it would read, CalPERS core values are ingrained in the work that we do every day. These values drive us to be transparent, accountable, and ethical to achieve CalPERS goals. As a leader, the CalPERS health program shall engage in activities that influence the state and federal policy landscape and align with other entities who share our values. And then we would enumerate the other 6 values underneath, the other 6 beliefs underneath. So the 2 different options are laid out for you in option 1, which is on attachment 1, and option 2 is on attachment 2. We're actually recommending option 1, which is to have this statement as part of the introduction. And primarily that's because the policy leadership theme is a little bit different from the other belief areas. And the policy leadership theme seems a little more strategic in nature. So that's why we thought it would be, from our perspective anyways, a little bit more of a tool to achieve our other theme belief areas. If that makes sense. So at this point, we've walked through each of the theme areas and the options that are available, and I would very much like to open it up for discussion, and then we'll move on to finalizing the beliefs, and after you make an approval of a set, we will work with Public Affairs to get those beliefs published. So if you have any feedback for us.
Thank you. Before I go to questions, I do want to say I want to thank you and your staff for listening to the committee last month and taking a lot of information back and coming back with, I think, was a very fine product. So thank everyone for a job well done.
Thank you very much.
Ms. Mother.
Thank you. Well, I agree. I think the process was very effective and got us to a place that I am very comfortable with. So I am prepared to move option 1. I guess that is my motion. I just want to suggest that option 1, which incorporates the policy. I'm sorry. The seconder was, I think, Mr. Slayton. That incorporates the legislative engagement is a departure from what we did on the pension beliefs. So we might want to revisit the pension beliefs at some point. I mean, I can't remember. It's been a few years since we looked at them in any case, but at some point we might want to revisit them and just align them or, but thanks.
All right, we have a motion before us, moved by Mother, seconded by Slayton. We have a few other people who wish to speak. Just want to make sure everybody clearly understands. You explained which the option 1 is as compared to this last item?
Yes. Option 1 has the policy leadership in the introductory verbiage because it's a foundational bedrock piece of what we do to accomplish the other belief areas.
Very good, thank you. Mr. Jones.
Yeah, thank you, Mr. Chair. I can support option 1, but I do have one question on high quality care. The term unwarranted care, we had a lengthy discussion at the offsite, and I thought it was an agreement that we would remove that and replace it with unnecessary care. So when did it come back to unwarranted? I just remember a lengthy discussion on that.
Actually, part of the discussion last month was to have unwarranted care. It's just a terminology that we typically use when we're looking at care that is not necessary. We actually discussed inappropriate, unwanted, unnecessary. There were quite a few words that were thrown out for this particular belief, and last month it came back with some comments that we should go back to the maximizing high value and reducing unwarranted, because we talk about that in so many other areas of our health program.
Okay, I just think unwarranted is not the, because we all want health care.
Well, it's not unwanted, it's unwarranted.
Warranted, okay. All right, okay.
Thank you, Ms. Taylor.
Thank you very much. I want to also thank your team for working so hard on this. I know we were going back and forth for each session and making sure that we were understood, and you guys came back, and I just thought the process was really a great process. So I also would support option 1. So thank you very much, you guys.
Thank you.
Thank you. Mr. LaFaso.
Thank you, Mr. Chair. Just one minor comment. Ms. Polish, in your narrative on the competitive plan choice item, you referenced both cost containment and innovation, but there's no mention of innovation in the belief. Was that an intentional iteration in the process I missed, or?
No, it's just my personal take on what that means to our program.
Okay. It was persuasive. I thought adding innovation might make sense, but I'll leave that to the committee. Thank you.
Very good, thank you. Seeing no other requests, we have a motion before us. All in favor say aye. Aye. Opposed, no. Motion carries. Thank you very much.
Thank you very much.
Job well done. Bringing us to item 6, strategy for reference pricing pharmaceuticals. Ms. Donison.
Good afternoon, Mr. Chair, members of the committee. This is a presentation on a proposed pilot for 2019 to reference price pharmaceuticals by therapeutic class. Today I'm going to talk to you, provide you with a little bit of the background on the journey we've been through in order to come to our own proposed pilot. Talk about pricing strategies that we have provided to you and how this fits with those strategies. talk about the analysis that we conducted, and talk about what the member might experience in terms of an example, and then talk about next steps. Reference pricing by therapeutic class offers pricing transparency as in addition to a way for both the health plan, which is CalPERS, and the members to save money on some different pricing options. At the January offsite, you heard from a panel that talked about reference pricing as part of a strategy. Between February and March, we went back and we looked at proposing some, not just reference pricing as a strategy, but a series of strategies for 2018 and 19. And we're here today to talk about the results of the analysis that we have concluded so that we can recommend this pilot. If we're successful, it will replace the member pays the difference program, and it may eliminate most utilization management processes such as prior authorization and step therapy. It also, reference pricing by therapeutic class also improves transparency to us as the plan and to our members, and it provides options for members to have a lower cost drug when they choose a therapeutic alternative or equivalent. For this pilot, we wanted to start with a few classes. Now, I know your agenda item talks about how others have done this and the numbers of classes, and we did do a lot of work to see other models, although this is where we are in the development of our own. We looked at 16 different therapeutic classes. Some of them we were worried about offering as a pilot, such as diabetes drugs. We felt that would be complicated. There are other mental health classes that we looked at and chose not to go into that area. So we selected 3 classes of drugs. They're all naturally made in the body, and they also have they have many equivalents and alternatives, and we believe that the ones that we've whittled down to are appropriate for a pilot. The ones we're recommending are the nasal corticosteroids, which are used for things like allergic rhinitis, which is allergies with sneezing, thyroid medications, and estrogens. The reason we selected these 3 was low generic use, additional formulary options, and a low rebate impact. I want to provide you with an example of how reference pricing by therapeutic class works. We're using a drug that was available in 2017, and by the way, all of our analysis was based on 2017 claims data. The non-preferred brand is Nasonex, and its cost in 2017 was $123.70 per month. The member would pay a $50 copay, and CalPERS would pay the remaining $73.70. Mometazone is a Tier 1 generic that is available for $97.41. The member would pay $10, and CalPERS would pay $87.41. Fluticasone is a therapeutic class alternative that costs $3.65. It is the generic alternative to Nasonex, and at $3.65, the member would pay that amount, and CalPERS would pay $0. If we had reference priced in 2017 and the member taking Nasonex switched to fluticasone, the member would pay $3.65, and CalPERS would save the $73.70. So that's an example of how reference pricing would work. Now, the member retains the same options that they had with member pays the difference. They can ask the doctor to switch them to the therapeutic class alternative or equivalent to lower their prescription drug costs. They also could ask for a medical necessity determination, which is associated with all of our programs, or they can continue to use the medication and pay the cost difference. Now, based on another program that implemented a similar program, about 85% of patients offered the therapeutic class alternative made the switch. Another 1 to 3% asked for an exemption through medical necessity, and 12% continued to want to pay the retail price. So there's still choice for our members in terms of how they wish to spend their dollars for their pharmaceuticals. Reference pricing optimizes cost alternatives across the therapeutic classes when clinically appropriate. For our next steps, we will come back with further analysis in terms of this is a recommended pilot for 2019. If approved by the board, which could either be in May or June, we would provide extensive pharmacy and provider outreach, and then we would again come back in 2020 and or 2019 at a later date and provide further updates. That concludes my presentation, and I'm happy to answer questions.
Thank you, and I hope as part of our process that we're not just expecting the members to ask their doctor to go to a lower priced drug, that we're going to actually educate the providers as well, so that the doctors can start recommending a safe alternative that's a lower cost.
That's correct. And also that brings us to our other pilot, the academic detailing pilot, which is kicking off this year, in which we will be really addressing the physician side of prescribing in terms of our formulary. This is a possibility. I did get a feedback from one of our physicians who said this is used in Germany. It makes sense to a physician. They don't have to worry about a formulary if they know that they can pick from a therapeutic class.
Great, thank you. Mr. Miller.
Yeah, two things. One thing, I just, with this particular example, it kind of looks like it would cost CalPERS more for the person to choose the generic, the mometasone, but to go to the therapeutic equivalent, the member would drop from $10 to about $4, and I'm not sure how compelling that would be to them versus, if there was more of an incentive there, like zero maybe for that alternative. But my real question is, you mentioned that there was a few percent that asked for a necessity exception. Do you know what percentage of those were actually approved of those 2 or 3% that asked for it? Or was that what was approved? I'm interested in that, the success ratio for folks that ask for that. What's their experience? How many times do they have to ask? How many of them actually get it versus what percentage are ultimately denied, and how that works?
These statistics were taken from another program. We do, though, run our own medical necessity determinations through our appeals process under Dr. Sun. We'll go back and find out, a little more detail around the 1 to 3%. Yeah. But in general, we ourselves, once they've had a determination made by the health plan, the member can continue to appeal all the way to us. And under Dr. Sun, we manage that appeal, and they can appeal actually all the way to the board.
Great, thank you.
Thank you. Mr. LaFaso.
Thank you, Mr. Chair. I wanted to get a bit of a handle on therapeutic equivalents and alternatives as we're going forward. I did some, I won't call it sophisticated research. So what I learned was there are 2 kinds of corticosteroids, gluco and mineral. I'm not sure if those apply to nasal. I know that's a narrower zone. I looked up something in the range of 25 to 50 estrogen drugs. The vast majority were under the same generic name, but they came in, some were gels, some were injections, some were, I think, maybe ingestible. Throwing those examples out, can you give me a sense of what therapeutic alternatives really are? I mean, is it not a therapeutic alternative if the means of administration are different? Are there chemical subsets that make things equivalent or non-equivalent, or, sort of on the margin?
Well, and I'm probably going to have my pharmacist come up and help with some of those questions, but the therapeutic equivalents have the same equivalent ingredients. So they are equivalent ingredients. They may differ in terms of maybe some additional additives. The alternatives are they're not equivalent, but they are an acceptable evidence-based alternative, and they can both be within a therapeutic class. And now, if Melissa could come up and help answer that question.
Thank you. Melissa Manton, CalPERS team member. You're correct. There are different type of corticosteroids, and the one that we're recommending is specifically to the inhaled corticosteroid that are used through intranasal for allergic rhinitis. And in regards to your question about the different estrogens, you're absolutely right. There are a lot of different subclasses, and we do need to flesh out the subclasses under estrogen because there are some oral product, there's vaginal, there's topical. So the next step in the further analysis is to further narrow down the sub-therapeutic classes for estrogens.
Okay, appreciate it. Appreciate the perspective on the steps going forward.
Okay.
Just one more follow-up on Mr. Miller's question. Is the medical necessity process in this going to look a lot like the medical necessity process for our other reference pricing programs for the non-prescription drug? And can you elaborate, if so?
Yes, the answer is yes. We do manage the appeal process. If it gets turned down through the PBM, it comes to us to further adjudicate in terms of the member, and we collect medical records, and we, in some instances, contact the physician. So yes, the medical necessity determination is a pretty standardized process in terms of how we manage our appeals.
I guess the bottom line question is, if a regular PBM prior authorization process largely relies on the judgment of a physician, and this relies on the judgment of a physician, what fundamentally is the difference between those two processes?
I don't believe there are. Go ahead, Melissa.
I believe it is the same process that currently is in place for other formulary requests. If a member needs a medication and does not meet the utilization criteria, it's the same process. The physician needs to provide medical justification why the member may not use or cannot use a formulary alternatives. And the decision is rendered based on that information. If the decision is a denial and the member and the prescriber feel that or it does not agree with the decision, then they can have their appeal rights consistent with the plans and the CalPERS. That is external review as afforded by the Affordable Care Act. And then in addition is the CalPERS administrative review rights.
Appreciate that. But I think the essence of your answer is it's in the utilization criteria. And in your response to my prior question, we're still working on exactly how that works. So I appreciate all the answers. Thank you.
Thank you. Mr. Slayton.
Thank you, Mr. Chair. So on the third, how do you pronounce the
Fluticasone.
Fluticasone. That's Flonase as a over-the-counter, right? That's what we're talking about as one of the brands that's out there.
Yes.
But it is over-the-counter.
That's one of the brand name for Fluticasone.
So my question is, we go into this, do you have an estimate for what you expect to see in savings from this on our side and on the member side? What's your projection?
Part of the analysis is going to be looking at the subclasses. We have done some high-level analysis of savings, but we need to flesh that out a little bit more in terms of the subclasses and those that we would actually recommend within the therapeutic class for the reference price. So we're still working on many of those things.
But you're not making it your decision subject to some determination of the number. In other words, you plan on going forward with this as a reference pilot. Is that?
Mr. Slayton, this is an information item, and
Right.
the goal is to get have a dialogue about it, and then what we'll be doing is bring it back for a decision in front of this committee as a part of a benefit design, and then we'll have the savings and a lot of that detailed analysis you're looking for.
But it will still be in the framework of a pilot.
Correct.
Okay, thank you.
All right. Thank you. Seeing no other requests, we do have one request from the public. Neil Johnson, please come down to your right, my left. The microphone will be on for you. Please speak your name for the record, and you'll have up to 3 minutes, please.
Neil Johnson, SEIU 1000. While we're supportive of the concept, and reference pricing has been around in a variety of forms for years, your hip and knee replacement procedures is an example of that. But one of the things, and Mr. Slayton sort of touched on this in his question, we get, and this I think has been done a number of times, we have these pilot projects, but we don't really know what the objective is. We don't have a hypothesis we can test. Maybe there is one, but it's not brought before you as part of that decision process. And I would hope that at some point we start actually looking at how do we evaluate the pilot. What are we really looking for it to do? Cost impact, is it better outcomes, whatever, and have that paradigm set up before we actually launch into the pilot. With that, I thank you very much.
Thank you. Bring us to agenda item 7, Preferred Provider Organization, PPO 2018 design. Ms. Donison.
Mr. Chair, members of the committee, Kathy Donison, CalPERS team member. Today I'm going to update you on benefit designs that we launched in 2018. It's still early in 2018, so these are preliminary. And I won't focus on every item that's in the agenda because we need to collect more claims information, but our intent is to come back and periodically update you on how we're doing. I'll begin with the benefit design changes that became effective this year, which is covered in your agenda. I then want to cover 2 new programs that we want to elaborate a little more. Ms. Bailey Crimmins talked about them in her opening remarks, but I'd like to give you a little more detail on those 2. And then I'll discuss any benefit designs that we might be coming back to ask for approval in 2019. First, I want to talk about the many benefit designs that we offered. As I said, don't have information on all of these to date, but I do want to update you on 3. Ambulatory Surgery Center reference pricing, the Castlight pilot, and Silver Sneakers. And I would like to address a little bit of Mr. Johnson's comments in terms of evaluation. Absolutely, when we do these pilots, we do have an evaluation period, and many of the reference pricing efforts that we did for hips and knees and for the 3 ambulatory surgery center pilots were done, rigorously done by both internal staff and the University of California at Berkeley. And the conclusion that Dr. Robinson, who did the evaluation, came to, the reason we reference price is that there's a lot of variation in pricing across different procedures and, of course, as I illustrated, across different therapeutic classes and tiers. And so we absolutely agree that pilots should be evaluated and the merits presented not just to the board but to the public at large. And so really reference pricing is a market approach to decrease the amount of variation in any procedure or any drugs. So I just wanted to let you know that's why we felt it's not only important to expand in the ambulatory surgery center space, but also to look at reference pricing by therapeutic class as well. Now, to the ambulatory surgery centers, we proposed 12 in 2017, which went into effect in 2018. We added, in addition to the 3 in place, so we have 3 classes, or 15 procedures in ambulatory surgery centers that are underway. We also have been careful in terms of how we look at what to reference price. They have to be safe, that is low risk, and sometimes you have to wait for technology to catch up in order to be able to say it can safely be done in an ambulatory surgery center. So it really has been several years since we've had this conversation. But as we expected in the ambulatory surgery results that only encompass the first 2 months, our highest variable and potentially potential for standardizing price is in the upper GI endoscopies with biopsy, without biopsy, and laparoscopic gallbladder surgeries. For those of you who are new to this committee, we have studied our population health for several years, and our number 4, a high-cost set of conditions, is in the GI tract. So we kind of expected that we would see those would start to rise to the top. And even within 2 months, for just 3 of those 12 classes introduced, we've now saved about $420,000. So you can see that it's not just, it's safety, it's evidence, it's quality, but it's also trying to drive down the variation in pricing that occurs within our markets. Now I'd like to move on to Castlight. We've been disappointed in Castlight. You approved it for 2018. You heard presentations throughout 2017 on what benefits was being derived by our membership. We've had 2 or 3 years to try to get the Castlight tool to be increased in use. It is based, what we pay is based on households, and yet only about 22% of our households today continue to use the Castlight tool. I did want to let you know that on page 3 of your written agenda item, the savings was identified as $270,000. That is simply that's not an annual, that's a year-to-date expense. The expense that we will be avoiding if you agree to terminate the Castlight contract would be $1.8 million in 2019. We are working with Anthem to try to find a replacement transparency tool. And then finally, Silver Sneakers, an update. We don't yet have enough claims to be able to look at savings from the program, but I will tell you that we had 7,000 members enroll in January. That's 5% of the Medicare PPO population, and nearly 25% of those members are over the age of 80. And again, this is a Silver Sneakers promotes an exercise, strength training, and flexibility program, which is important to our members as they age, especially as they get to the more frail age groups. I'd now like to talk to you about Spine Zone and Wisdom that was mentioned by Leanna. These 2 programs are meant to really look at overuse, underuse, and misuse of services, especially as they pertain to the back. And the back in this instance is not just the low back, it's the mid back and the neck. So this is an evidence-based program that is preventative, so there's no copay. There's also no increase in administrative expenses. And the intent is to reduce back surgeries by offering non-surgical control of back and neck pain. This program is designed to empower the patient to engage with their physician and with the physician staff that are part of the Spine Zone team. It uses a coaching system. There's an online program, and then there's an in-clinic program. So right now, the clinics are down south, but they're moving north, and we expect to see a Spine Zone clinic up here in the latter part of 2018. But really, the whole point of Spine Zone is to look at the entire musculoskeletal frame. There are support muscles, and then there are muscles that support us, and then there are muscles used to do things like lift and bend. And sometimes the non-support muscles get used, and then you may have an acute back pain occur. So it looks at the whole back, and it tests the musculature of the neck, that supports the head, the mid-back, and the low back. And through that personalized analysis, a member can then have a tailored back program. Now, backs in back injury can be acute, or it can be chronic, or it can come as a result of the aging process, just the body getting tired. So the individual diagnosis is done, and then the resistance training, coaching, and exercises are prescribed. And it is managed by spine surgeons, physician assistants, physical therapists, and other assistants, and kinesiologists that are part of the program. Sharp Health Plan has rolled this out, and they feel that it is very promising, and we do as well. And all PPO members can participate. The other program is a study, and it is called Wisdom, and it's a new approach to breast cancer screening. And it looks at a personalized set of diagnostic tests in terms of high risk versus low risk. And if a patient is determined to be high risk, then recommended additional resources and potentially additional tests are prescribed. It doesn't replace any of the current programs we have. It is a study, and it is voluntary. And we'll continue to work with Anthem to let you know how these programs are going once we roll them out. Next, I'd like to talk about the benefit proposals for 2019. We are going to come back and ask for two. The first would be a copay change for urgent care and specialty care. And the second would be to add a reference price to 3 therapeutic classes. I'd like to talk about the copay change from $20 to $30 and let you know that we have not changed the copays for PERS Care and PERS Choice for several years, over 13 years in fact. But our market has changed, and it's changed in an interesting way. And that is, we offer the urgent care copay at $20, the same as a primary care physician copay. And that copay has existed in a market that has now grown to have many urgent care centers available. And we do like having urgent care centers available as an alternative to the more expensive emergency rooms. But the market itself has also changed in terms of how primary care is being delivered. They're being delivered in clinics within pharmacies. They're being delivered in clinics within retail stores. And we do start to see a fragmentation in terms of how our members may be using those types of setting versus the primary care setting. So I just wanted you to think about that as you deliberate about the change in the copay. Also, these are higher both in urgent care and specialty care. It's higher levels of care, and we believe that some additional copay for that level of care is warranted. And we are not recommending at this time any change to the coinsurance or the deductibles. And the second one is reference pricing, which I've already discussed with you. That then takes us to our next steps. We will continue to track our benefit design changes and the value that is accruing that we implemented in 2018. We will come back in May or June for some decisions about 2019. We will embed some of these savings, especially with the ambulatory surgery centers, into projected expense of premiums for 2019. So we do want to look at including those savings as part of premium reduction. And then we will continue to monitor and implement our programs for their effectiveness. And that concludes my presentation.
Thank you. We have a number of requests. Ms. Mother.
Thank you. Well, I think one of the things that this presentation highlights is that when we do establish a pilot program, we do monitor it, and then if it's successful, we continue it, and if it's not successful, we close it down. And I think that is the case with the Castlight product. It just did not work for our members. For whatever reason, our members did not utilize it, and it was not worth the investment that we were making in it. So I thank you for bringing it back to us for reconsideration. I think it's an important part of the pilot assessment process and determining whether these things should be embedded over the long term in how we approach healthcare. So that's really important. I did have a question about the ambulatory surgery centers piece. You said that there are $420,000 of savings. Do you know, and 1,759 procedures since the beginning of the year. Do you know what that number of ambulatory surgery center procedures was last year, what the comparison is? It's hard to know how big or small that number is out of context.
Thank you. We did not reference price last year, so, but we do have data that supported what we expected to save. And for all 12, we expected to save a little over $3 million. So this is 3, but it is the big 3. But we expect we're on track for those savings, and quite possibly it could go above that. The 1,700 figure also includes the numbers that we have for arthroscopy, colonoscopy, and retinal surgery. So that is 1,700 is for the full set of 15. And
that's for the 1,700 for the full set of 15.
Yeah. If you would like, we can continue to let time go by and continue to collect this data and bring it back.
I guess what I'm wondering is, have we seen an uptick? I mean, is the 1,759 an uptick over what before we reference priced? Are we seeing more people using ambulatory surgery centers? I guess we must if we're seeing some savings. But I guess that's the number I'm trying to get at.
Right. We're not there yet. We will be. If you'll remember when we did the 3, arthroscopy, colonoscopy, and cataract surgery, we saw movement out of the outpatient hospitals of up to about 90%. So again, we have demonstrated savings in terms of the original 3, and it's well documented. So we can go back and continue to look.
Thank you. I want to raise one other thing, and that is with respect to the copay changes. We had a public comment this morning in Finance Committee questioning the rationale for increasing copays at a time when we have excess reserves in the PPO plans, and I was wondering if you had an answer to that question.
We are going to be looking at a reserving policy. Mr. McCollum and myself will be working with external actuaries to try to find the source of why excess reserves could be building up. So that is another piece of work that we are undertaking that looks at that side, the reserves. My rationale for asking for a $20 to $35 copay increase is really more so to reflect the market cost and some of the market behaviors that are happening in terms of our members using more fragmented care in some of these retail and pharmacy centers versus seeing their primary care physician.
So are you really trying to drive a change in behavior? You're trying to drive people to the primary, is it really that, or maybe you can expand on that a little bit?
It's partly to continue. It's partly to continue to look at, does a $20 copay at an urgent care, which is the same as the primary care, move members into different sites of care that may be more costly? Urgent care centers are more costly. Retail clinics are probably less costly, but, and I say that because they're using nurse practitioners and physician assistants under the rubric of the medical ownership. But in a way, that may be fragmenting care away from primary care. So part of it is it's an economic reality that those are more higher cost sites of care. But secondly, by keeping them equivalent as these new sites of care come up, it may be driving members away from the primary care physician.
And you think this is the best way to modify behavior, changing the copay from 20 to 35? You think that's the most effective strategy or approach?
And just as a reminder, the number that Mr. McCollum had given was an aggregate across all, and we have numerous sub-accounts. And so when he was talking about that, the $120 million, it's in a scheme of a $9 billion fund. And if you saw the charts, there are certain plans that have a lot more reserves and then other plans that are less reserves. Our job is to ensure from an administration, what is that the typical reserve, and then what we're going to be coming back in June, as Dr. Johnson was talking about what is too much and what is too little, and then having a policy that the board can say, do we have a premium holiday? What could we actually do with those excess reserves? And that will be coming to this committee in June.
So then that would be a policy that would that we would review periodically. Establish a process by which we review the excess reserves or the status of the reserves.
Correct. And just also, it was a December 2017 date. If there has been any reserve changes, it's not reflective necessarily for 2018. So it was a point in time. So just letting people know that was last year's. There may have been changes that have already occurred there.
Okay. Thank you.
Thank you. Mr. Miller.
Yeah, thank you for the very informative presentation and all the staff work, I'm sure, that's behind it and has got in. I've two areas I want to kind of revisit and touch on. One is the cast light example, and then the other is also this increase in the copays. So one of the things that struck me with one of Mr. Slayton's questions and Mr. Johnson's comments was, and having not been here for the run-up to these pilots, is it will be really helpful for me to understand as we go forward to see that when we design the pilots, from the get-go, we're talking about what does success look like on a pilot, and not just purely the financials, because I'm sure we've got, you know, objectives, goals, targets, projections of what success means there, but also in terms of what are the other things we've got to look at for that pilot to be a success, whether it's patient experience, numbers of people choosing something, satisfaction, dissatisfaction, perhaps not as far as engagement measures, but to have that designed in up front, knowing that, you know, here's how often we're going to check in, or this variance from what we're projecting will cause us to say, whoa, do we need to take an action? Do we need to modify? Do we need to terminate? And have that designed into the pilot in a very transparent way up front, so we don't get 2 or 3 years down the line and say, well, kind of looks like this didn't work. So if we had the crystal ball, if we had that set up, if we brought Cast Light's performance to date back in time and said, here's what you're going to be looking at, you know, in 2 years or 3 years, do you want to do this? We shouldn't be figuring that out, you know, down the line much further. So, and whether that's incremental or a go, no-go point or a, you know, percent variance from plan, I don't know. But something to really think about design phase up front. And when it comes to the increases in the copays, I understand the desire to try to get a handle on what degree of, you know, financial pain will cause someone to make a different choice, particularly if that person is in financially rough straits, which many people that higher acuity, fixed income, a retiree or a meagerly paid public employee. And so I wonder whether figuring that out by making just a 75% increase, well, why not go to 100? Why not go 50? Without giving us some alternatives of what is the value of trying to get that information figured out versus the impact on our members, and how many iterations of trial and error do we do before we say, oh, that's what worked best. I'm not sure I'm sold on that approach for getting that information, so.
Thank you. I think you spoke very well in terms of actually understanding our goals for our program. We have set a goal of affordability and sustainability. So we really try to look at our strategic plan as guiding our efforts. And in terms of some of the market changes, maybe we better go back and take another look at and update ourselves in terms of what is actually happening. We've got consolidation going on out in our market. You could have, the reason we've got members moving to ambulatory surgery centers is that evidence shows they're actually as safe or even better safety and quality. But a hospital system's response to that could be, well, let's just buy the surgery centers. And that's what we're thinking, that's what we're seeing too. We've got market consolidation going on with the PBMs and the health plans. So yes, we're down a little bit in the weeds on some of this, but it's within the context of how markets are changing. And as you're well aware, we have not changed our copays on our pharmaceutical. I think the last time was 2005 too. So we're very careful about looking at trying to balance copay changes versus trying to encourage the best programs for our members to engage in evidence-based medicine. So that is our guiding principle, which is part of the principles that you just approved. But we do need to watch our market, and we do need to, whether it's a copay increase or not, we've got to pay attention to what's happening in our market, what changes are going to be threats to affordability and sustainability. In terms of our pharmacy programs, one of the reasons that I've offered reference pricing by therapeutic class as an alternative, it's an alternative to more tiers in our formulary. It actually is, in many respects, a better approach than managing high-cost generics, which are inflating, as a Tier 2 versus a Tier 1, or specialty drugs as a Tier 4 or a Tier 5. So we do try to look at the context in which we are presenting our design changes and our pilots. And should you decide that the copay should stay the same or go up and ask us to go back and do more work, we'll be happy to do that. But we will not be coming back for a decision until May or June. So
yeah, thank you.
You don't have to decide today.
Yeah, and again, I just, I appreciate where our focus is, but I think we need to, at least for me, I try to see a little bit more rather than a kind of these unitary, these one-dimensional kind of measures of success. I think we need to, go a little beyond that, at least in terms of explaining it to me, that I can see that, yeah, we can save some money here, but I also want to see, yeah, we're improving the patient experience, we're improving outcomes, our members are happier, they're more satisfied, they're more engaged with us as a result of what we've done in this pilot, or at least we didn't hurt that in generating some savings.
Thank you. Mr. Gillihan.
Thank you, Mr. Chair. So on to one of my favorite subjects, silver sneakers. As some of you may recall, I was a bit skeptical of this when we adopted it last year, I guess. So it doesn't look like it's off to a strong start, at least based on the numbers here. I realize it's early, but it would seem like if there's pent-up demand for something like this, the initial signups would be more reflective of the demand than what we're seeing here. So my questions are, remind me how much we're paying to make this service available, because I know it's at no charge to the participants.
Each visit is $4.25 up to a maximum of $5.14. The $5.14 is set as a ceiling just in case every PPO Medicare member decided to engage in terms of taking advantage of it. So far, right now, we're in the numerical range of $4.25 per visit. So it's not our expectation that everyone is going to either want to or be able to participate, but that's currently where we are.
And I assume we're locked into this for 2019 unless the board makes some decision, but presumably we're so early into this experience that it's probably a decision point for the 2020.
Correct.
Right? Is that correct? And so it would be about this time next year when we would revisit this?
Correct. But in that time, we will be collecting data in terms of the benefits of silver sneakers, as well as connecting, as we wanted to any reduction in pharmacy or medical costs.
Right, assuming there's any benefit. But and I recall at the time we did it, the chair at the time gave staff direction to bring that analysis back, and so we're still on track to do that.
Well, I just want to also, you're not locked in. Obviously we've only had 2 months of claims, so it's too early. It's early, but May is when we make the decision on benefit designs for 2019. We would recommend, from a staff recommendation, that we give ourselves a full year of experience before we make any decisions.
By locked in, I meant, I think it's too early to make a decision. If the decision was made to try it, we need to at least give it a shot. And so that was, I guess, the point of my locked in comment. Thank you.
Thank you, Mr. LaFaso.
Thank you, Mr. Chair. I don't want to let go by uncommented upon, Dr. Donison. I know how much effort you put into to find cost-effective ways of improving spinal health, but since it's not controversial, I won't comment on it anymore. I think you well got through the pilot issue with Mr. Miller. I guess I appreciate what you said about the sort of the big strategic issues about the way the marketplace is reacting in an investor sense to all the things we're doing. I don't know what to add in terms, but what Mr. Miller said about trying to zero it down to the consumer experience really resonates. And I know we talk about it. For example, you alluded to what you presented to us last year when we were expanding the reference pricing, which was the related improvement in quality with the expertise associated with the surgery center. So I guess at some point it's a presentation issue. Moving along, on the cast light issue, we're still, of course, another pilot we're talking about. Can you elaborate on what we think we've learned from cast light? And you mentioned working with Anthem. And I'll be honest with you, I was a little, I asked myself questions after the January offsite about our focus on a relationship with One Health Plan in terms of our approach to technology tools. What I'm really trying to ask is, what did we learn and what are we thinking in the future in terms of technology tools that where we're trying to get to in terms of technology tools for our members?
I'll start with the evaluation of cast light, this is a continuation really of that discussion that started with a professor who evaluated cast light with Dr. David Cowling of our branch, who is a scientist, a research scientist and manager. I was disappointed when the evaluation came out. I was disappointed that the promise of cast light, which was a transparency tool to allow say a new mom looking for doctors in the area to select from, and it was for the PPO, and it was for the PPO basic members only, looking for a doctor to select from which they could see quality scores. They could look to see distance from home. And I really thought this was a good transparency tool, which we introduced, I believe, in 2012 or so. And so, that was its intent, to allow, as we did reference pricing, to allow our members to have one place to go to understand the reference price, to see the effect of the reference price in terms of what they would pay through their benefit design. Some of the members, some of the households did use that tool. Some used it really to search doctors in the local area. To me, the unfortunate thing about cast light had to do with the fact that it's based on households, and when you have a pilot such as this, there has to be energy kind of put into the pilot. Cast light was a new company at the time. It was a promising company. We engaged cast light through Anthem, and the 22% who are using it must have value. We just wish that it had been more, and we wish that the evaluation study had turned out differently.
Mr. LaFaso, I'm just going to expand on that. What we have learned, what you're going to see in this agenda item that maybe you haven't seen in prior years, is that you will, Ms. Kathy Donison actually showed you what the benefits from the prior year. Typically at this time of year, we're only talking about net new. We're not actually saying what were the results of the prior year. And so if we are in a pilot, we should be bringing back, as we've talked about silver sneakers, if we're in a pilot stage, every year we should be talking about, are we on mark, are we not, and at any point in time, do we continue or do we stop? Cast light obviously has been here, and it actually went from pilot to program, so it had been a program for a while. And what we believe we owe to you is, for the April agenda item, is not only net new, but tell you about what you approved last year and where we stand in relation to those benefit designs. I think that helps you continue to have a pulse of what's going on, and do we want to continue.
But if I understand correctly, the essential thing behind Castlight is assisting members in their provider choices. Are we sure that A, that's what members want in terms of a technology tool, or B, maybe that's what we want because we see that as a cost driver? But are there other things that maybe consumers want that if they had that, then they might be attracted to this thing that maybe, I don't know, I actually don't know if members are, I mean, I know members want the best doctor, but of course they want convenience, they don't want to get out of network, they want to know who's in, there's lots of things they want that don't have a direct relationship to what we want, which is, you know, cost-effective provider choices. Anyway, I'm throwing a bunch of things out there, but I guess the question is, are we attracting them with what they want to get them to do what we want?
We will be working with Anthem. Well, one, we need to evaluate where we are with Castlight once it's done. So we've done an evaluation. It was done by an academic. It was done under the auspices of our Center for Innovation at the time. So we need to really look at where, at the end of the year, where we got to. The other is we do want to take those lessons learned and use it to work with Anthem to look at a potentially new transparency tool.
And also, you're talking not just only looking in the rearview mirror, you're talking about looking forward. So when it comes to technology, being a prior CIO for many, many years, you have to be at the pulse of what your members want. Our retirees have talked about if we're getting rid of paper, can we do more app-type devices on their smartphones? So you talk about the user experience and you get a pulse of what your members, both active and retirees, want. You see if there's technology out there that meets the needs. You figure out if you do it through a third-party administrator. So there will be more of that to come. That's kind of my strength, is understanding how to implement technologies that matter to members. Castlight was not one. They thought the behavior members would shop, and there was a thought that that was going to happen, and that did not happen. Should we have pulled the trigger sooner? Hindsight's always 20/20. But I'm glad that with this board and this group that we did make the right decision today not to move forward with that.
Appreciate that.
Thank you. Mr. Jones.
Yeah, thank you, Mr. Chair. The first question I had is also what Mrs. Mather was referring to earlier today in the Finance Committee about the proper level of the reserve. So I'll hold my question until June when you bring that report back. The other question I have is the estimated savings of $11.8 million, and is that savings coming from the two changes of the urgent care copay and the specialty copay?
Yes, that's correct.
So we're just shifting then, because if I'm a member and you raise my copay and now you reduce my per member cost, right? And I'm looking at this as $50 maybe for the PERS choice. So that you're just changing where you're getting the money from. Is that correct? Because you said I'm going to increase your copay from 20 to 35, and then you're going to decrease my per member charge of $4.70. So why are we just switching like that? Why?
It's premium savings. So the savings that we reflected in the agenda item lowered the premiums.
The premiums for the member?
So it's obviously it's too early to be talking. I mean, from a premium perspective, that will come in preliminary May. But any savings that CalPERS gets in relation to the system drives down premiums. We're not allowed to have a huge number of reserves. So that's one of the things we're going to be doing, is bringing back in June as a reserve policy. But the reason that the reason that we've talked about the copay going up is in basically in 13 years, the cost of care has gone up for specialty care, and the copay stayed $20. It's reflective of the market increase, and that's what the $15 increase is. A specialty care should cost more than a primary care physician. The same thing with urgent care. That also has gone up. Emergency room services, obviously that's co-insurance, so that's a very different situation. But it's not a cost shift. It's care has gone up in the last 13 years, and the copay should reflect the increase in cost.
But the overall premium for medical care has gone up anyway.
Correct.
The cost is, for how long you say, 13 years? The cost has already gone up, and so we've already increased the cost to pay for that increased cost. So why do we need to raise the cost for the member to?
So the premiums are based on the last year and a half of experience, and so we set a premium, and people's co-pays are the out-of-pocket cost of what their fare.
That's the part I'm addressing.
Right. So maybe you can explain, Kathy, of.
Right. If you reduce the premium, it's a savings to both the member as well as to the plan. And it's the PPO and we are the plan. So it's not that the member doesn't save. The member does save. We can bring back those figures and show them to you in May.
I'd like to, along with that reserve question too, so, because it has an impact.
And I think it's confusing because we're talking about reserves, premiums, deductibles, and copays. This specifically is just a copay, but we'd be happy to bring back something that shows how those all
Okay, I appreciate it. But when I look at this chart, the 11.8 million is the savings as a result of the copays. Okay.
Correct.
Thank you. Mr. Miller.
I'll try to be really quick with this. Kind of to Henry's point, one of the things that strikes me is when costs go up and we adjust our premiums, we're distributing those costs and we're sharing those increases between the individuals, the employer, across all individuals, regardless of their individual needs or usage patterns. When we make a 75 or 100% increase to copays, it very specifically hits the people who are higher acuity or have the needs for those services, with the assumption that somehow we'll change some behavior that people may or may not have needed to access those, but it's not distributed, and it just seems like there's a real philosophical question there about, do we want to differentially impose those higher burdens on the people who most need those types of healthcare services versus distributing those costs and trying to address it in our, in all the other ways we're trying to address costs. So that's kind of my comment, not so much a question, but a concern.
Mr. Slayton?
So I'll take the kind of the opposite view, which is, the premium is spreading the cost over the entire base. And so to the extent that people see a specialist versus their primary care doc, that is now subsidized. If the price stays the same, it's subsidized by everybody in the plan. So, it is a philosophical question of how much do you want people to bear the cost or some of the cost of their decision versus have that cost be subsidized by the entire plan participants. So, it's never easy to make an adjustment in price, but I think what I sense is going on is we're trying to encourage people to use the skill sets of their primary care physician in all cases where they can. Some cases they won't be able to, and to the extent they do, then they don't incur an additional cost. So that would be my view of it. So I'm less concerned.
Mr. Jones, do you have something else?
Yeah, just another question that's triggered based on Mr. Slayton's comment. The urgent care copay, that's when someone has an immediate urgency and they go into some facility, and that's where the copay. But on the specialty copay, doesn't a primary physician refer the patients to this benefit?
In the PPO program for Care and Choice, they can go direct to the specialist without primary care.
Okay.
All right, seeing no other requests, that brings us to agenda item 8. Thank you, Ms. Donison. Brings us to agenda item 8, summary of committee direction. Pardon me, there's request to speak from Mr. Larry Woodson. And Mr. Woodson, after you speak, just stay there because you'll be back up shortly.
Well, I'll try to make this brief because I'm late for my silver sneakers class.
Take Mr. Gillian with you.
Okay. Larry Woodson, California State Retirees, thank you for the opportunity to comment. I'd like to inform board members, as I did stakeholders with the staff on Thursday, about recent attention focused on major shortcomings in the quality of care nationwide at ambulatory surgical centers. CSR supported CalPERS' VBID proposal for adding 12 additional procedures to be done at ASCs instead of outpatient hospital facilities, and we still do, with qualification. We asked staff at the time, it was proposed, if the quality of care and medical outcomes were equivalent to hospital surgeries, and they assured us they were. And that's probably what the research data shows to date. Staff reports that for the first 2 months of 2018, there have been 1,759 claims. There's been cost savings, but there's no medical outcome information collected or reported. Kaiser Health News published a well-researched article in March titled, "As Surgery Centers Boom, Patients Are Paying with Their Lives." I provided copies to staff last Thursday after stakeholders, after discussing it there. I encouraged them to share it with you. It describes the proliferation of ASCs over the last 10 years, and there are something like 5,700 certified by Medicare throughout the United States, many more than there are hospitals, and certainly less regulated and less monitored than hospitals. The article documents ASCs that are poorly staffed, not well equipped with emergency equipment, poorly trained staff in ER procedures, long distances from hospitals and ER rooms, especially in rural areas, and they found that they've identified 260 patients that had died in the last 4 years after in and out procedures at ASCs across the country. Dozens died after routine procedures such as colonoscopies and tonsillectomies, which, by the way, are procedures included in the 12 added design procedures. After reading the article, a couple of weeks later, I had a personal experience with an 87-year-old man who I know well as a CalPERS plan retiree, covered, who had a very dangerous experience during recovery at an ASC in the Sacramento area, fairly remote from a hospital. And there were no doctors remaining on site after the surgery. He was finally stabilized, but it drove home some of the points in the article. And certainly the majority of centers are well staffed and equipped, but the report shows, or the article shows, greater vigilance is needed. In conclusion, that we did ask staff how ASCs they are utilizing are certified and who regulates them in California, and they agreed to provide that, and we're looking forward to that. But relying solely on physicians' judgment to determine where to perform these procedures is clearly not enough, as demonstrated in this article. So in conclusion, we think it's important that CalPERS evaluate and report on quality of care where members are having these procedures done, in addition to reporting the number of claims processed at ASCs. Thank you very much.
Thank you. Brings us to agenda item 8, summary of committee direction. Ms. Bailey-Crimmins.
Mr. Chair, the one item that I have for action is to bring back statistics specific to CalPERS regarding therapeutic classes and PBMs, and specifically medical necessities. We will be bringing that back. I didn't take it in as a board directive, but I did want to at least acknowledge that we will be potentially reviewing the pension beliefs, and then also the additional analysis that had been requested to in relation to the benefits design, copays, and how they relate to premiums. I think from an education perspective that we need to understand that as we're making these decisions.
Very good. Thank you. Mr. Jones, did you have something else?
Yes, I did. The request that he mentioned that you had agreed to provide some information on this subject matter that he just talked about, and I would just say, Mr. Chairman, when that's done, if we could also get that information.
The committee, the full board will get a copy of whatever they turn in.
Okay.
That is correct.
All right. Seeing nothing else, agenda item 9, public comment. Mr. Woodson.
All right. Thank you, Mr. Chair, again. I I think I'll just start off by saying that CSR does oppose the increase to $35 for copay. And I understand the logic, and I'm not sure it will really serve as a disincentive or as an incentive for seeing people seeing their primary care physician. If you have 104 temperature on a weekend, you don't have access to your primary care provider. And keep in mind too, the $30,000 a year median pensioner. I can afford $35, but some people, it's a bigger hit. Okay, we are concerned about potential increases to cost for some of our members in the health plans, especially the PPO plans. And especially because CalPERS decided to abandon the practice of risk adjustment in setting premium rates. It's been an applied practice for 5 years, and each year staff has characterized it as a positive exercise in maintaining parity among the cost of plans and making the highest cost plans more affordable to members. And part of the rationale has been that higher cost plans usually reflect different member demographics, namely older and sicker members. So we're especially concerned this impact may have on over 30,000 PERS Care members, since PERS Care has one of the higher rates, if not risk adjusted. And there's a strong likelihood that without risk adjustment, monthly premium contribution limits will fall well short of the unadjusted premium. There are several other plans where this will likely affect members as well. In discussing this with staff and stakeholders last week, the rationale we were given was that by not doing risk adjustment, about 79% of covered members would see their premiums go down, while only a small percentage would have theirs increase. So for the overall good, this is a good idea. And that argument that more members would benefit is sort of misleading for especially fully vested retirees, since the vast majority of the lower cost plans, even adjusted, risk adjusted, are fully covered by the contribution levels of CalPERS. So in conclusion, although PERS Care Basic is the most expensive of the 3 self-funded plans, it's sometimes misrepresented as being a Cadillac plan, and that really isn't the case when you consider that members have to pay 10% of all non-preventative care, in addition to the $500 or $1,000 deductible for a family. And there are 18 counties where HMOs are not available, so people are forced to take these plans. Even where HMOs are available, sometimes members join a PPO to retain the providers that they already had. So I thank you for your time.
Thank you. Thank you for your comments. So seeing nothing else on our agenda, this open session is adjourned. We will go into closed session at 2:15. See you all next month.